Good morning, everybody. My name is Dr. Marta Statucka. Please feel free to call me Marta. It's much easier than trying to pronounce my last name. And though neurophysiology sounds really cool, I am actually not a neurophysiologist. I'm a neuropsychologist, slightly different specialty. And since many of you may never have come across a neuropsychologist in your life, I want to just start off at the beginning to tell you a little bit about what it is we do and how we could be helpful in some ways. So it's true that a neuropsychologist is a psychologist, a PhD in psychology, with a specialty in neuropsychology. And what that means is that we assess people's thinking abilities or cognition. So you would come into our clinic and we would do tests to assess your attention, your memory, your language skills, how quickly and efficiently you could solve problems. And we do that in a very interactive way. So it's not sitting at a computer, it's not writing essays at a desk like you might have done in school. Many people describe the test to me as being almost like board games or brain teasers. They're very interactive, they're kind of challenging, they push you in some ways. They can be frustrating, I will admit. And we do this fulsome assessment to, like I said, assess all different aspects of cognition. And so neuropsychologists can work in a number of different areas or fields. Some people specialize in pediatrics, where they assess children to diagnose things like learning disabilities, ADHD, dyslexia. Other neuropsychologists work with people with brain injuries. Some work in memory clinics where they help diagnose different forms of dementia. And myself, I work as part of the deep brain stimulation team at Toronto Western Hospital. And so my job is to assess people before they go for surgery to see whether they would be a good candidate or if there's any contraindications because of their thinking abilities to going forth with the surgery. And I also follow up about 1 year after surgery with each of our patients to see how they're doing after their brain surgery. And then also on an ongoing basis. So sometimes people come to us 5, 10, even 15 years after surgery saying, you know, I've noticed some changes in my thinking abilities. I'm wondering if this is just normal, healthy aging. This is how my brain should be working at 80. Or if there are some changes because of Parkinson's disease, or is there something else going on in my brain? So we follow up patients, like I said, kind of on a regular basis to see how they're doing. So, as I mentioned, I'm just a member of our interdisciplinary team, which involves our neurologists, or our great team in the movement disorder clinic. There's 2 neurologists that specialize in DBS, plus their fellows that trickle in every year. We have a wonderful neuropsychiatrist that is also part of the preoperative assessment and follows up people after surgery as well. There's 2 neuropsychologists, so myself and my colleague, Dr. Melanie Cohn. She looks like a clone of me almost. We are identical, except she has a French accent and I don't. So that's the only way you can really tell us apart. And then our very talented team of neurosurgeons who actually perform the surgery and follow up with people afterwards when they need battery replacements and things like that. So I am just, like I said, one member of this large team. There are fellows that participate. There are, of course, nurses at each level here that also assist and are very involved with our patients. So I'm just one little cog in the wheel, and I'm going to be kind of speaking from our general perspective, but again, I'm just kind of one representative of this very large and kind of involved team that you would be seeing if you did a preoperative DBS assessment at Toronto Western Hospital. So today I'm hoping to speak to you about kind of 5 common misconceptions that I hear when my patients come into my office. We do the neuropsychological assessment, but as a psychologist, I have the luxury, I would say, of speaking with people for a pretty extended period of time. So usually in the morning before the actual testing starts, I would spend probably about 45 minutes to an hour with the patient, learning about their history, getting to know them a little bit better. And at the end of the assessment, again, maybe spend 20 to 30 minutes with them, telling them about the results and answering any questions that they have. So since I have, like I said, the luxury of so much time with people, they often bring questions to me and they often give me a sense of how they're feeling about DBS, whether they're very gung-ho or they have their hesitations. And so it really gives me the opportunity to kind of hear them out, hear about their expectations, their hopes, and answer questions that they have. And so these are kind of 5 things that I hear over and over again that are slight misunderstandings or misconceptions, as I said, about DBS, the process, what the outcomes can be and what have you. So I wanted to kind of tell you about them and tell you where sort of a more accurate or kind of middle ground lies that's not so extreme as some of these misconceptions suggest, or like I said, maybe where there's a little bit more of an accurate response than what people bring to me. Okay, so these are the 5 misconceptions that we'll go through, and of course I'll leave time at the end for some questions for you guys. So one of the most common misconceptions that I hear is many people come to me saying, well, DBS is the last resort. I've tried every medication that's on the market. I've done physiotherapy. I've done every other thing that I could possibly do. I've considered other kind of more experimental things, and DBS is the only thing that's left to me. And part of this misconception comes from the idea that DBS is experimental. So many people come to me and say, well, this is not like a real treatment. It's, it's still kind of on the fringes. And that's not really true. It was experimental at some point. That's absolutely true. In the 90s, there was some very famous neurosurgeons in our hospital doing DBS on an experimental kind of level. And there are some disorders and diseases that DBS is still experimental for. But for Parkinson's, it's actually been approved by the FDA since 2002, and it is completely covered by OHIP. Okay? So it's not experimental. It's a well-established treatment for Parkinson's. It's done in many centers around the world. Our center at the Toronto Western Hospital, I think, is 5th in the world in terms of the number of surgeries that we do. So this is an established treatment. It's not experimental anymore. But again, people, even if they know that it's not experimental, still kind of tend to think that it is something that they should consider only after a very long period of having Parkinson's disease, when they've tried, like I said, every other medication and every other treatment under the sun. And it's true that when the surgery was first being done, there was a meta-analysis in 2006 that showed that people were having DBS around 14 years of disease duration, so quite a long period of time. And if you look at our numbers in our clinic, you can see that after it was approved by the FDA and supported by OHIP, the average disease duration that people were considering surgery was about 13 years after being diagnosed. Those numbers have decreased over time, as you can see here. And it's true that people are considering DBS sooner, and I'll talk about why that might be in just a second. But considering DBS at a very kind of late stage in the disease process has a lot of things that kind of go along with it. One thing that I learned, I was speaking to my psychometrist, who is the person that actually administers and scores those tests that I mentioned earlier, and she's been with our clinic for over 20 years doing these preoperative assessments. And she told me that it's true that many people were considering DBS as a last resort very late into their disease process in the early 2000s. And she told me that people were in a very bad state when they were making this consideration, and patients were often so dyskinetic that they could not sit in a chair and they had to lie on the ground while Tasha was trying to administer these different tests. Or they simply couldn't tolerate the 4 hours, let's say, of assessment, and they had to come back 3 or 4 times just to complete an assessment. So they were in quite a bad state when they were making this kind of decision about having DBS, and it really was their last resort. They had tried everything else that was available to them, and only, like I said, after a very long disease duration were they kind of making this a consideration for DBS. So the numbers have come down. As you can see, now the average is about 10 years after diagnosis that people are considering DBS. And there is an important rationale for this. So Dr. Fasano, who's one of the neurologists in our movement disorder clinic, and his colleague Dr. Dershel, in 2012 published a very well-known paper where they recommended that DBS actually be considered closer to 7 years after a diagnosis. And this little graph that I'm showing you here is kind of their reasoning for why. So in the top graph, you can see that as can be expected, as Parkinson's progresses, you see that there's a decline in motor functioning, right? So that's the orange or the red line that you see there. If we do DBS kind of later in the disease process, an unfortunate side effect of that is that people's psychosocial functioning also declines over time. So they may reduce their activities of that bring them joy. They no longer participate in family gatherings because they might feel embarrassed by some of their symptoms, or it might be difficult for them to get to and from those kinds of celebrations. There might be other things. They might have to stop working because of their motor symptoms. And so a lot of things they've had to kind of reduce or kind of eliminate from their daily lives because the motor symptoms are starting to get in the way. The rationale is, if we do DBS kind of later in the disease process, it's very difficult to kind of start all those activities back up again. So what makes more sense is to maybe do DBS a little bit earlier before all those activities have kind of started to trickle away, so we could sort of rescue the psychosocial functioning as well. So we're helping the motor symptoms, but at the same time, we're kind of helping the person's psychosocial functioning at the same time, because we don't have to start things up from zero. We can kind of ramp things up that we haven't completely given up yet, which is an important feature. And then there was 1 year later a very famous study called the Early STIM trial that was published that also showed, this was a randomized control trial. So they took people and they randomly assigned them to either best medical treatment, so medication, or DBS at about 7.5 years after diagnosis. And what we could see is that people who got DBS actually had not only better motor functioning, but they also had better quality of life and better participation in activities of daily living than people that just had best medical treatment. So these two kind of studies and publications really informed our kind of thinking that DBS should probably be done a little bit earlier in the disease process, because there are kind of benefits outside of just motor functioning that can happen if we do the surgery a little bit earlier rather than later. There we go. And so we can see here that the shortest disease duration when people are having DBS in our clinic at Toronto Western Hospital has gone down. This 1.5 years in the most recent kind of 2-year band is a bit of an outlier. So I don't anticipate that many people would consider DBS so early in their disease process. But there are some people that are very, very sensitive to side effects of medication, who really cannot tolerate taking medications, or who find that it really doesn't help their symptom of primary concern. And so they would consider DBS so early in their disease course. Again, that's not to say that that's for everybody and that everybody should have DBS right off the bat, but there are some circumstances where it might be appropriate to consider DBS even kind of earlier in the disease process. So that's kind of the takeaway from these slides. All right, so the second thing that I wanted to talk about, the second misconception, is that there is an age limitation. That after a certain age, DBS should not be considered, will not be done, it's not safe, it's not a good option. So there is actually no formal age limitation for DBS. So you might have heard that there is. Some people have come to me and said, well, it's not covered by OHIP after age 70. And that's absolutely not true. There is no formal written down age limitation for DBS. However, many people kind of consider the age of 70 as sort of being a limit. And there's a number of reasons for that. So over the years, since we've been doing DBS and doing this research, there is a correlation or a relationship between having DBS at an older age and having less of a motor improvement. So people who have DBS earlier in their 60s, 50s, tend to have kind of more improvement if we measure it kind of on different scales in terms of pre-DBS and post-DBS than people who have surgery kind of after the age of 69 in their 70s. Okay, so less motor improvement. That sounds like maybe a good rationale for not risking this type of surgery. Another issue is that it is also correlated with more surgical complications. So as you can all probably imagine, as we get older, having any type of surgery is associated with more complications. If you have a knee surgery at the age of 80, there's more risk of complications than if you had that same surgery at the age of 70. We have more comorbidities, we have more kind of other disorders that can get in the way, high blood pressure, high cholesterol, all these things increase our risk of having a surgery. And the same is true for DBS. So if you have DBS after the age of 70, it's true that there is a higher risk of having something like a hemorrhage or delirium after the surgery. That is true. And then another very kind of important publication in this world came from my predecessor in the neuropsychology clinic, Dr. Jean St-Cyr, who published a study based on those experimental DBS patients that had DBS in the 90s. And what he found, and his colleagues, was that patients who had the surgery after the age of 69 had more cognitive decline post-DBS than those who had surgery before. So this is one of the reasons why I have a job as a neuropsychologist, is to assess people before and after surgery to see if there has been a decline after surgery. And so this very early study, like I said, published in 2000, based on people that got DBS in the 90s, when it was still experimental, showed that people who had surgery later in life had more of a cognitive decline than those who had surgery earlier in life. So basically, it's starting to look a little bit like this. If you have DBS after the age of 70, you have less motor benefit, you have a greater risk of surgical complications, and there's a greater risk of cognitive decline. It's not looking very good for the case for DBS after the age of 70. The risks are clearly kind of balancing the benefits. And so this is the reason why many centers, for many years, would kind of draw a line in the sand at age 70 and say, after age 70, we will not consider you for DBS. It's just too risky. The risks outweigh the benefits. However, there are some important things to consider. So, as I mentioned, the study that was published and about cognition, about thinking abilities in DBS was done in 2000, and it's complicated for a number of reasons. So one of the things that's very important to consider is, again, those patients that were having DBS when it was still an experimental procedure were considering this kind of towards the end or a very long kind of disease process. But the average disease duration was about 15 years in that study. So they had had Parkinson's for a very long time. They had tried everything else on the market. It was kind of their last resort. And back in 2000, we did not have the diagnostic criteria that we have now for Parkinson's disease and the cognitive issues that come along with it. So there was no way of diagnosing mild cognitive impairment caused by Parkinson's disease. There was no way of diagnosing Parkinson's disease dementia. There was no formal criteria for that at that time. So in this paper, they did not apply those diagnoses because they were just not available. However, if I look at the data, which I have access to, and I can look at the numbers, I can see that these people were having very significant cognitive issues at the time of surgery. So their age perhaps wasn't the reason why they had these declines after surgery. It might be that their thinking abilities were already quite compromised to begin with, and that's something that we'll touch on in the next misconception. But I think that these patients currently would have been excluded from surgery, probably based on other things and not because of their age. Okay, so it's complicated. The study made it seem like really it's the fact that something about age 70 is magical, and if you hit age 70, something happens, and there's no going back. But I think it's a little bit more complicated and a little bit more nuanced than that, and there's a number of different factors that could explain the cognitive decline, not just age. And the reason why this is important is I do believe, and we've seen in our clinic, that when we do proper patient selection, that DBS, even if you're over the age of 70, even if you're in your mid-70s, can be helpful and beneficial and can be safe. Okay, so we now have a very kind of robust preoperative assessment. We call it the 2-day assessment, where people are seen by neuropsychology, neuropsychiatry. They have a levodopa challenge. And so they're assessed in all different ways to determine whether they would be a good DBS candidate. And if there are any contraindications that are discovered, that could be for somebody in their 60s, that could be somebody in their 70s. We counsel and we kind of advise the patient about what would be the best and safest option for them. And so, again, with this kind of more thorough assessment before surgery, I think that we can find really good candidates who are in their 70s, who would still benefit from DBS and for whom it would be a safe procedure. And we see this every day in our clinic. And so I often tell patients that, there are very healthy, active, functionally intact, wonderful 70-year-olds that could really benefit from this surgery, and we've seen them. And then there are people who are in their 60s and 50s who, for whatever reason, have already very compromised cognitive abilities, for example, who are really doing very poorly in terms of their thinking abilities, or who have a very kind of aggressive form of Parkinson's that's progressed very quickly. And so even, after a few years of disease duration, they're doing quite poorly, and they have some symptoms that might be contraindications for DBS. And so there's no, again, perfect age at which DBS should happen, but there's also no kind of hard limit as to when DBS can't happen. And so you can see here that certainly the average age at which people are having DBS has increased over the years. Early on, it was kind of in the mid to late 50s, and now we're having patients more kind of in their early 60s as the average age. However, I think the more important thing on this slide that you should take away is that, in the early 2000s, after that study was published by St. Cyr et al., really age 70 was kind of the cutoff, right? That one person that was 70.7 sneaked by. Maybe they were a superstar and they were really good on all other kind of metrics and doing really well. And so there was one person in their 70s who managed to get DBS. But as the years have gone on, not only has the kind of oldest age at which DBS is done, has that increased, but also the number of people in their 70s who have had DBS has also increased at our center. And so these people, again, as I mentioned at the beginning, we follow up with them after DBS. So I do see these people about 1 year after surgery, and then as needed, 5 years or 10 years after surgery as well. And they do not, hit a cliff and fall off in terms of their cognition. Many of them are doing very well. They have the same kind of pattern of cognitive cognitive functioning as people who get DBS in their 50s and 60s. And so I don't see this, this cause for alarm about having surgery after the age of 70. Many people, like I said, are doing quite well, very happy with their DBS outcome in terms of their motor functioning, and doing quite well from a cognitive perspective as well. So again, there's no written in stone age limit for DBS. 70, there are some considerations about complications and, doing a thorough assessment before surgery, but there's no absolute cutoff age. Okay, so I touched a little bit about cognitive limitations. The reason I have a job is because there are some things that we look out for before DBS that would make a person not a great candidate to move forward with that surgical option. So, a proper cognitive assessment with a neuropsychologist is considered the gold standard in terms of a preoperative assessment. There are some things that can be done even before you see a neuropsychologist to kind of gauge whether this would be a good idea to move forward and to use those resources. But really that very thorough cognitive assessment that I described before to assess memory, attention, thinking speed, and so forth, really that is the gold standard and what should be done preoperatively. So it is true that having dementia is a contraindication for DBS. DBS, the process itself, the surgery, the follow-up afterwards, is a very interactive, iterative process. And so unfortunately, many people with dementia would not be able to kind of actively participate in that kind of process, which is one of the reasons why we consider dementia as a contraindication. Another reason is that, kind of hearkening back to that Jean St. Cyr study, if people have already very compromised thinking skills, to the level of dementia before DBS, those are the people that I really worry about, that, putting electrodes in their brain, going through the surgical process, anesthesia, all those things that increase risk of complications, all that could kind of cause their cognition to really decline after DBS. And so, like I said, dementia, at the kind of bare minimum, if I detect that during my assessment, that would be a contraindication for moving forward. Our team in the Movement Disorder Clinic is very good at kind of doing a basic assessment to begin with and filtering out people who would really meet dementia criteria and not kind of proceeding on with a 2-day assessment. Not every clinic is like that, and so it's very rare in my practice that I actually see anybody with a dementia, because usually they would be earlier on identified and told that DBS is probably not a good option for them. And so at many centers, that is the case. And so we often do not see people with dementia as part of the neuropsychology assessment. However, we do see people with various levels of cognitive functioning. Some people are superstars. I've had, astrophysicists in my clinic. I've had all sorts of people with very, fascinating jobs, amazing careers that have done wonderful things, that have IQs in the 140s. They're geniuses. They're doing amazing in terms of their cognition. And then we have average schmoes like myself who have an average IQ and get by just fine in their world, and they can participate in activities that they enjoy, and they participate in clubs and what have you, and they're doing well. There's no issues with their cognition. They're just average like the rest of us, and there's nothing wrong with that. But then there are people that have quite significant changes in their thinking abilities because of Parkinson's disease. And those people, for some, in some instances, would be excluded from DBS because of the level of cognitive difficulty that they're having. Okay, and so that is actually the most common reason why at our center and at other centers, people might be told that DBS is not a good, safe option for them because their cognition, their thinking skills are already so compromised by the disease. However, one thing that I will warn you about is that there is no single test that should be used to make that decision. Okay, so I have had people come to my office and say, well, I went to my family doctor, I went to my community neurologist, and I said, you know what, I'd be interested in DBS. And they pulled out this one sheet of paper, and they gave me a little test where I had to draw a cube, and I had to name 3 animals, and I had to learn a list of 5 words. I see some people smiling. You've probably had to do this at your neurologist at one point or another. So that's called the MOCA. It's a very kind of quick and easy cognitive screener. And again, people have come to me and said, my neurologist pulled this out. I did this test. It took about 5 to 10 minutes. And they said, you didn't do so great on that test, so I'm not going to, refer you to a DBS clinic because I don't think you would be considered as a candidate. And that is absolutely not appropriate. There is no single test. There is no single cutoff score that could be used to make that determination. Again, the gold standard is to get a thorough, let's say 4-hour assessment with a neuropsychologist like myself to see if there are strengths and weaknesses in the person's cognitive functioning, if there are, if a diagnosis of dementia is made based on that very thorough assessment. But it does take a few hours of cognitive testing, a few hours of poking and prodding to make that determination. It should not be based on a single test. It should not be based on a pass-fail score. There's no such thing like that. So if anybody tells you, you didn't name those 3 animals quite perfectly and you wouldn't be considered, that's absolutely not true, and you should push to get a more thorough assessment. Okay. So another thing I want to spend a little bit of time chatting about is the weight and the importance that patients place on having the surgery versus the follow-up. Okay? So oftentimes when I see people in the preoperative assessment, as you might expect, they're very preoccupied with getting to surgery. What is the wait time? How long does it take? What's the recovery? When can I start playing golf again or swimming again? And so that's really where their bulk of their headspace is at. To put things in a little bit of perspective, the surgery itself is, at this point, pretty easy. I mean, I'm not a brain surgeon, so I can't speak to that exactly, but the surgery itself is not a very long surgery. It's about 5 to 7.5 hours. That can happen in one kind of bout or split up across 2 surgeries, one a little bit longer that involves the brain implant, and the other a little bit shorter that involves placing the battery pack. But it's not a hugely long procedure. And then many people are shocked to find out that after having a brain surgery, they only have to stay in the hospital 2 or 3 days. Some people do stay a little bit longer, if it's a weekend, for example, and the doctor's not available to discharge you for some reason, or if there's a little complication, you might have to stay a bit longer. But it's very rare that people stay longer than 3 days in the hospital. So again, a lot of brain space is being used to worry about the surgery and what that means, but the procedure itself is actually pretty swift, and the stay in the hospital is also pretty short. However, that should be contrasted with what happens after the surgery. So the programming is a very important part of having DBS. It is not a magic switch that you turn on and everything works perfectly, your tremor is gone, your gait is wonderful, everything's hunky-dory. It does not work like that, unfortunately. So you are sent home from the hospital about 2 or 3 days after the surgery, and you stay at home for 6 weeks recovering, waiting for incisions to heal and kind of getting back to your regular life. And then once you come into the clinic, the whole system is turned on. But again, it's not a magic switch. It doesn't make everything great. It is an iterative process after that. So you come in, and the nurse practitioner or the neurologist sets up the different kind of parameters. So they see you in the clinic, they see how your tremor is, they turn on the stimulator, and they try to set the settings so that the tremor goes down. And then you're sent home. You kind of observe yourself over the week. Maybe a few hours after that session, things get a little bit worse, or a new symptom comes up, or you become very dyskinetic. You come back a week later, you tell the team what happened, they adjust the stimulation parameters. You go home for a week, you come back, adjust. And so most people do about 5 sessions like that over 5 or 6 weeks. Okay, so again, it's an iterative process. It's not one switch and everything is done. It can become a little bit more complicated because sometimes medications have to be adjusted in hand with the stimulation, so things have to kind of balance out. So sometimes we're increasing stimulation but decreasing medication at the same time, so it becomes a little bit more complicated. So again, it's a lot of back and forth. You have to be a good reporter. You have to keep track of things, tell your team what's going on so they can kind of chase down those symptoms and address them as needed. So that's one part. So again, those 5 weeks, once the stimulation starts, is intense. There's a lot of back and forth in terms of traveling to the clinic and what have you, and also kind of keeping track of your symptoms and how you're feeling on a day-to-day basis. Then there's also the issue of battery changes. So for most people, kind of at the current stimulations that we're using, need a battery change about every 2 to 4 years. That's the standard battery. So every 2 to 4 years, you have to come back for a day surgery where the old battery is taken out from under your clavicle, a new battery is put in and hooked up to the system DBS in your brain. There are now new rechargeable batteries on the market where it seems like they will last about 15 years. Some people say even 20 years, but they're new on the market, so we'll see how well they do in terms of that. So it's less onerous in terms of having those battery changes, but with a rechargeable battery comes having to recharge it. So yeah, you have to be, if you're one of those people that's always running on like one red line on your phone, maybe the rechargeable option is not for you because it does have to be recharged regularly or it stops working. The last I heard, if you let it, I think, come down to 0, the battery life come down to 0 twice, the battery stops working altogether. It cannot be recharged, and then you have to get your battery replaced sooner than the 15 years, which is expensive, okay? So again, you have to be a person that's pretty good with rechargeable rechargeables and sitting still for an hour while it recharges in order to consider that option. So that's another thing to consider. The battery changes are another kind of involvement that has to happen after DBS. And one other thing that's very important to consider is that DBS is kind of a lifelong process. So oftentimes people ask me, and this is another kind of mini misconception, when does it stop working? When does it run out? It doesn't run out. If you have a battery that's working, DBS is working. It might not work in the same way. It might not address all your symptoms as your disease progresses, but it still works. It is not taken out after a specific number of years. People have asked me that, like, oh, so when do they take it out? It does not get taken out. It stays in there. Taking it out could actually introduce more risks than just, having the DBS system in. So it works differently, but it's still there. And many people come back probably about 6 months to a year each year to kind of have a tune-up. So they'll come in, the neurologist will do an assessment, see what type of symptoms they're experiencing, see if any kind of changes in the parameters could be made at that time, see if any medications need to be adjusted. And again, that's probably about every 6 to 12 months that people do that assessment. So it is a lifelong process. Again, it's not a magic button that gets turned on, you get sent home, and you're done forever. There's work to be done after the surgery happens. And so I feel like for many patients, they're very focused on getting to surgery, but they don't necessarily think about the work that has to happen after the surgery happens, which again is something to consider. It's not for everybody. Not everybody wants that level of involvement. Not everybody lives nearby to a movement disorder center where they could just hop by every week. It's not that convenient for everybody. So it is an important consideration to be had. All right, and for my last misconception, I want to talk about this idea that DBS is really the only thing that's available to you. Many people have seen these videos online where people do that fun party trick where they turn off and on their DBS and they're tremoring, and then they turn it on and they're like, look at me, I don't have a tremor. And so it seems very cool. It seems like a very, again, advanced, very modern option to have, and people are very focused on having this type of surgery. But it's not the only option in terms of advanced therapies for Parkinson's disease. There are a number of other options, surgical and otherwise, brain surgery and otherwise. And so when you come to a specialized movement disorder clinic, a specialized DBS program, often what happens is that you're not being assessed just for DBS. You're being assessed for all sorts of different surgical options, and DBS is maybe the most kind of involved preoperative assessment, but if for whatever reason we find that you would not be a good candidate for DBS, or you don't want DBS in the end of the road, there are other options that the team could present to you and say, well, maybe DBS is not on the table, but have you considered focused ultrasound or duodopa, for example? Okay, so again, you might be going through an assessment for DBS, but that's not to say that other options are not being considered and kind of weighed in the process. However, the important thing to think about as well is that each of these surgical options have pros and cons. There's no perfect option, and not everything works. It's not a one-size-fits-all. So for DBS, one of the reasons why many centers kind of focus on DBS, and that's kind of the first line that they consider, is this kind of adjustable element of it. So as I mentioned, you would come into the movement disorder clinic multiple times at the beginning to set up your parameters, and then on a 6 to 12 month basis to kind of fine tune and adjust things. So that adjustability, that kind of ability to chase down symptoms as they might appear, as things change, is one of the most kind of desirable things about DBS. It addresses many symptoms, so it's not just that it addresses tremor or just dystonia. If you kind of place the electrodes in the right areas of the brain and you kind of set up your stimulation appropriately, you can actually address many symptoms of Parkinson's, not just one or two. For many people, an important aspect of DBS is the ability to reduce their medications after surgery. That's not possible for everybody, and there are some types of DBS, flavors of DBS, if you will, where that's more possible than others. But for many people, that's a very important consideration, that they want to reduce their medication or simply simplify it. So some people are taking medications every 2 hours, one's with amantadines, one with Mirapex, one here, one there, and it becomes very complicated to follow. They can't eat protein during some certain times of the day, they can't do something else during other parts of the day, and so just that kind of complexity of their medications is quite tiring, and so they would like to kind of just simplify. And DBS, for many people, allows them to simplify or reduce their medications, which is also, like I said, desirable. However, there are some contraindications, some that we touched on before, like very poor cognition. Other issues could be very poor gait preoperatively, or very low or affected voice preoperatively that could get worse. So not everybody qualifies for DBS. And not everybody wants it. So many people have gone through the process with myself and the Movement Disorder Clinic, and at the end said, there's that 1% risk of X, whatever it is, during the surgery, and that's just intolerable to me. I can't even consider this type of surgery. Other people say, 1%, is there a cancellation tomorrow? Can I get on that surgical table tomorrow? So everybody kind of weighs the pros and cons, the risks and benefits differently. And like I said, some people go through the whole process, they learn about it, they see what their personal risk might be, what their symptoms could be like after surgery, and they decide that it's not for them, okay? And that's perfectly fine. So if that's the case, if somebody does not qualify or if somebody does not want DBS at the end, there are other options to consider. These two are ones that are offered at Toronto Western, but there are other surgical options out there as well that are offered at other hospitals. So focus ultrasound. I have had people come to my office and say, I want the one with the lasers. So it does seem very cool. There are lasers involved. It's not quite lasers, but it does kind of can be kind of shown that way. And again, it seems very futuristic. It seems very cool. People say, I want it because it's not a surgery. That's not necessarily true. It is a surgery. It's just a very cool, new, modern way to do a very old surgery. So there's no incisions made to the scalp. From my understanding, you do still have to shave part of your head. So if that's one of the reasons you're considering having focus ultrasound over DBS, that shouldn't be your consideration, because in both cases, part of the head has to be shaved. There's no incisions made with a scalpel, but that focus ultrasound is being used to cause a lesion or selectively damage a little part of the brain that's causing some of the symptoms. Okay? So again, it is a brain surgery. It's just not a brain surgery that uses a scalpel to get to the part of the brain that's being addressed. The other thing, one of the cons about this type of surgery is that it is not adjustable. So unlike DBS, you kind of get the lesion and it's there. You can't go in a year later and tweak it and make it a little bit bigger or a little bit smaller. It kind of is what it is, so you can't kind of adjust it. And in many centers, it's only done on one side of the brain to address one side of the body. So many centers think that it's too dangerous, too risky to do both sides of the brain, but bilateral surgery. So only one side of the brain would have this focus ultrasound done on it to address one side of the body. Okay? That might change, but currently that's kind of the thinking. And another surgical option that has nothing to do with the brain is duodopa, where there's a small pump placed in the duodenum, the small intestine, and that constantly kind of releases L-dopa into the system. So you do not have these kind of peaks and valleys throughout the day when your medication is wearing on and off. You just kind of have a steady flow of L-dopa throughout the day. You can think of it as sort of like an insulin pump that diabetics might have. That's kind of part of their body now, and it's there all the time releasing the medication that you need. One issue with this type of surgery is that since there is a prescription of a medication involved, right, if you do not have insurance, or if you're under the age of 65 and do not have your prescriptions paid for, it can be quite expensive. So our lovely duodopa nurse told me that it costs about $250 a day for the L-dopa gel. There are programs that people can apply for to have that covered. Subsidized, but not everybody qualifies for those programs. So again, it is something to consider, that it is a bit of a hefty price tag involved with this type of surgery. And another thing that many people have brought up to me is that the pump itself, it's not so nice and small as the insulin pumps. It is, a fairly sized thing that you have to carry around with you. And so if you want to go play pickleball or you want to travel, it might not be the most convenient thing to kind of haul around with you day in, day out. So it's not an option for everybody, both because of the cost and kind of the aesthetics of it. Some people will consider it, and some people have great benefit from it, but there are things that, that make it less desirable for some people, especially young, active people, than other options. Okay, so I think I'm doing well on time. Basically, my two take-home messages are these. So first of all, if you think that DBS or any type of advanced therapy would be a good option for you, I would like you to advocate for yourself. So if anybody tells you that it's too early for you to consider this type of therapy, that you're too old, you're close to 69, they'll never even see you in the clinic, or, you didn't do well in that one little test, you didn't name that camel, sorry. If anybody tells you for any of those kind of very simplistic reasons that you would not be a good candidate,
I would encourage you to advocate for yourself. Say, I would like a second opinion. I would like to be sent to this more advanced, tertiary clinic where they could do a more thorough assessment of all these different aspects involved to see whether I would be a good candidate. Because again, kind of this simplistic way of discouraging people or excluding people from the surgery is often a little bit too abrupt, and there are kind of more nuanced and things to consider that can make somebody a good DBS candidate despite some of these other factors. The other thing I would advocate for you to do is to educate yourself. So again, DBS, I think, is maybe one of the most known, the most famous types of advanced therapies, the one that you could find the most videos of on YouTube, but it's not the only option. There are other options that are, very effective, that many people have great benefit from. They're not for everybody, but DBS is also not for everybody. And so it's kind of important to know the lay of the land, to know what options are available to you, and again, to advocate for yourself to maybe get sent to a tertiary clinic where all those different options can be considered for your specific case. All right. So I would just like to thank some people that helped me in preparing this presentation. So Dr. Melanie Cohn, my clone. If you ever come to our clinic at the Movement Disorder Clinic, neuropsychology clinic, you will see that we are basically identical, except she has a French accent. I do not. She really helped me in preparing this presentation today. Dr. Anthony Lang helped me kind of learn a little bit about the history of DBS. My assistant, Tasha Chang, was the one that's been working in the DBS clinic for over 20 years and told me some of the stories of early DBS in the clinic. And then some of the wonderful nurses, Alex Darcia and Yu Yan, who are involved in the Movement Disorder Clinic and helped me kind of gather some of the stats and information about the different programs. Okay. No problem. Oh, thank you.